Hi, everyone. In just a few seconds, we will get started as we're waiting for people to come into the actual webinar. All right, let's get started. Welcome, everyone, to another wonderful Learn Your Benefits webinar. I'm your greeter, not your presenter, Brian Gazella, CEO and one of the co-founders here of Learn Your Benefits. Today's webinar is fantastic and critically timed for organizations who offer health plans. It's not about analytics. It's not about communications or open enrollment. It's about the new federal regulations, the potential legal liability stemming from them, and the opportunities to control your healthcare costs. The topic, navigating the new federal regulations for employers who offer health plans. We've gathered an amazing group of experts in the space. Your presenters are Mick Hannafin with Caveat Emptor Consulting, Patrick Williams with One Vision, and Deb with Innovu. They will be discussing the employer guidelines of the Consolidated Appropriations Act and review the new opportunities of the Hospital Transparency Act. Each of these people will introduce themselves at opportune times in the presentation. So at this point, let's get started. Take it over, team.
All right, I'm going to kick things off with the presentation. And the name of the presentation is Employee Loss Health Plan Management 101, Employee Lawsuits and Federal Audits. They are coming and how to avoid them. And let me jump through the agenda real quick. We're going to talk about your new obligations as a health plan decision maker, how to audit-proof your company and avoid being sued, leveraging the new rules and to drive down medical costs, developing a meaningful ROI for health risk and costs to ensure future compliance and save healthcare dollars. So before we get started, we're going to launch a poll just to get an idea of where you're at as far as from an education standpoint with hospital transparency and the Consolidated Appropriations Act. Looks like we're having some difficulty launching that.
It looks like the attendees have it. We don't see it on our screens here. I show 48, 67 presenting.
Okay.
Contributed. Okay.
So just a little discussion while we're waiting for everybody to wrap that up. It's, for me, being in the practice of providing a fiduciary process and governance to organizations, it's been enlightening to find out how many individuals that I come face to face with on a daily basis have never heard of the Consolidated Appropriations Act, or they've heard about the No Surprise Bill, but really didn't have an understanding of how transparency and coverage worked. And so our results are back. One being the least, and 5 being the highest. Is that how we're interpreting this? With 40%. Say again.
Mick says yes.
Yeah. Okay. So we have quite a few people that are participating in the presentation today that have very little knowledge when it comes to this legislation, which is this will be very good for you from the standpoint that you'll walk away with some good talking points and discussion points within your organization. So what was created as part of the legislation is 3 key pieces from a legal standpoint: the transparency and coverage, or TICRA, which really speaks to the plan data files required to be released to the public, In 2023, we've got a website that has to illustrate the top 500 shoppable services. In 2024, the website must support all required services to be listed. This is all in light of trying to provide transparency to the end user and the organizations, the employers in the marketplace with costs. The hospitality transparency rule, it was published, and really what that has done is provided information as far as what are the negotiated agreements amongst the various carriers. We're going to get a little deeper into this as part of the discussion, but also to provide patient tools that they can use to help estimate their costs. And again, this goes in line with trying to empower patients with the information they need so that they can make an appropriate decision in utilizing their health care. But the last piece, which is really kind of puts the wrapper on this perfect storm, is the Consolidated Appropriations Act. And that Consolidated Appropriations Act has basically 4 boxes that an employer has to be able to address. The first one is removing the prohibitive gag clauses from their contracts. And we've got some breaking news that's going to come that we're going to talk about in regards to that. And then second to that is the disclosure of compensation, both direct and indirect, from all covered service providers. And that's anybody that has anything to do with the health plan. So it goes from the broker to the TPA to the PBM. And the Department of Labor has been very clear in this, in their communication, that it's broader than just evaluating what your broker compensation is. The last 2 pieces is the required parity on mental health. Mental health legislation as was introduced probably 17 years ago, the last major piece of legislation. And what's interesting to notice is every time there's a new piece of mental health legislation, which was 7 years ago, they've also added a little tweak to the healthcare side. So mental health is very important to Congress, and literally to the point where Congress has invited the Department of Labor to come in and ask them how organizations are meeting the compliance requirements under mental health. So the DOL actually went out and performed audits and then had to report back to Congress. And the report back to Congress was 100% of the firms that they audited for mental health parity failed. And so this is still a big issue that's going on in the marketplace, especially with larger employers that are self-insured. There's steps that you need to address as far as meeting that compliance requirement. And the last piece is the prescription drug disclosure. And so those are the 4 components. The prescription drug obviously is providing information in regards that's coming from your plan to Health and Human Services as far as the cost of drugs and what you're paying for. They're gathering data from that standpoint. So we'll move on to the next page. Can't get my screen to advance. There we go. So let's talk about who's a fiduciary. And I think the first thing that we need to address from a fiduciary standpoint is that there's some terms that everybody needs to be familiar with. First of all, as an employer, you're a plan sponsor, and we've highlighted that in red. Okay. As a plan sponsor, you're a plan fiduciary. And these are terms that are used amongst people in the government and amongst advisors and consultants, but they're not as frequently recognized amongst employers. And so if you're an employer and you sponsor a health plan and it falls under ERISA, so the only way that would happen is if you might be in a church plan or some type of government plan, all of the other plans fall under ERISA. If you fall under ERISA, You're an employer, you're a plan sponsor, and you're a plan fiduciary. Now, there's some other areas to look to determine who's the plan fiduciary. The person that signs the 5500 has been deemed as a person that can be a plan fiduciary. And that 5500 is very important from the standpoint of it has all the financial information associated with the plan, and it requires a thorough input of information. So within that 5500, you've got your premium information, you've got your administration information, your compensation information is supposed to be in there. And so as an individual, if you're signing the 5500, you can be deemed a fiduciary, but you also need to make sure that the information that you're submitting on that 5500 is accurate. I can't tell you the number of times I've looked at 5500s and seen where claims data was inadvertently put into broker compensation. So all of a sudden you've got a broker compensation of $1.5 million, and you're scratching your head like, how did that happen? But the data wasn't accurate and it wasn't scrubbed appropriately. This is an area that they're going to start looking closer at as far as making sure that these submissions are accurate. But anybody that exercises discretion over plan assets, so when you look at your organization, if you're within your organization and you have a CFO and a CEO, maybe you have a small committee that gets together as far as part of an HR team that manages the vendor relationships. If you have any type of discretion over the plan design or the plan assets, you are going to be called in as a fiduciary. We even have situations where the claims administrator, whether you're a BUCA or TPA, based on the way the contract's written, can be called in as a plan fiduciary. So this is an area that people need to really focus on and get an understanding as to, first of all, who is the plan fiduciaries within our organization, who has control, and then are there any outside relationships that we have in the case of a TPA that might be a plan fiduciary. As part of the compensation and service requirements, part of what the Department of Labor has asked you to do is ask each one of the individuals that are supporting your health plan from an administration standpoint or consulting basis to understand what their fiduciary role is. And so we're encouraging you to do this and also document this on an annual basis, because you want to make sure that you understand which parties do have a fiduciary role and which parties don't. Okay. Next slide. So obviously this is kind of a rinse and repeat that we've seen out of the retirement plan industry. We've gone through this. We had the Pension Protection Act of 2006 that brought in transparency in the retirement plan space. And then we had the 408B2 legislation in 2011 that introduced the compensation disclosure. What they have done, the Department of Labor, IRS, Health and Human Services, is basically pick that language up out of those previous legislations and expanded 408B2 legislation within ERISA. Okay. So for the longest time, we had a situation where health plans weren't under the same guidelines as a retirement plan. Now today, they're the same. And what does that mean for you as an organization? It means the due diligence that you're doing with your retirement plan, where you're meeting on a quarterly basis and doing investment review and having a committee and organizing, all of those types of governance functions need to be expanded and brought over to your health plan. Some organizations we work with say, hey, we want the same people on the committee. That's a decision that each organization needs to make. But organizing a committee and starting to apply the fiduciary best practices is going to be very important to keeping you, the employer, the plan sponsor, the plan fiduciary, out of trouble. So what's happening here? we've got a number of lawsuits that have been filed that I'll just kind of give you some highlights on. We have a situation with Anthem, who's being sued by a couple of union plans from the standpoint that they've requested their data, which the data is eligible to you under the Consolidated Appropriations Act. It's clear as a bell that it's your data. They've refused to provide that information. What's important about that piece of uh, legal lawsuit that's going on is that if when that clears the way through the court system, and if it's found that that is the employer data, data is what I believe is going to be the ultimate play for the employer. You're receiving annual reports of your claims data, and typically we'll see organizations that they'll get these claims reports, and then at the end of reviewing the claims report, everyone's exhausted from looking at the numbers, and then they ask, well, what's the recommendation? And there's really never a recommendation. And so what happens is that inaction actually turns into a negative impact to the employer. That not taking any type of correction or corrective action from the data that's been presented to you can in turn be used against employers in the future. So what's really important for you is to start taking note of the claims reports that you're getting, understand what the impact is, and really starting to put together a plan of action to start addressing the underlying expenses within your health plan, and whether it's MSK, mental health, cardio, all of those require you to start, taking an active look at how you can manage that. Because ultimately what's happening here is employees are in a situation where they're frustrated. They have the high deductible health plans, and these are high deductible health plans that employers brought in because employers were frustrated with the health systems and the costs going up. So you have employees upset with high deductibles. They're bypassing a lot of the medical services until it's, dire need. And you have a situation where employers are not happy with health systems because they continue to have, a trend of at least 6.5% on their premiums on an annual basis. That's very difficult to keep up and pay for and offer as a benefit for employers. So we've got a situation where individuals are going to start experiencing, personal bankruptcy. The number one reason behind personal bankruptcy is medical claims. Okay. You're going to start seeing class action lawsuits surrounding a lot of the areas that we've bulleted on the left-hand side. So very important for employers to pay attention to this and start putting a plan of action. So we've kind of talked a little bit about ERISA and what plans are covered under ERISA. Well, they're your medical, dental, vision, HRA, FSA, EAP, and ICHRA plans. ICHRAs are individual contracts. What doesn't apply is life, disability, health indemnity, and any expected benefits or HRAs. So what's important here is when an organization is working with, a consultant or an advisor in the marketplace, these are the plans you need to focus on, but you really want to get a true picture of what is the total revenue that your broker's generating, because we've seen a lot of different scenarios here, and we've seen voluntary benefits come into the marketplace. And if you look, you don't see voluntary benefits on this list. But voluntary benefits has been the new play for advisors to shift to offset a lot of the expenses because of the rising costs of healthcare. So this is the actual, on the right-hand side is a listing of the class action lawsuit. Health plans can, in regards to the removal of gag clauses. And what's important is The employer health plan cannot enter into an agreement restricting the disclosure of certain information relating to the cost and quality. Plans must submit to an annual attestation to show that they are compliant with the requirements. And that's part of some information that we've got coming up for you. The new law takes effect for any contract executed or renewed after December 27th, 2021. So the reason why this piece of legislation and gag clauses is so important, it clears the pathway. It clears and eliminates the objection that an employer can give to say, well, I can't get access to my data, so I really can't do anything. This onus is on the employer to make sure that they get those gag clauses removed. In some cases, it's going to require an ERISA attorney to review the document or somebody that has expertise in reviewing these types of contracts. But by law, you cannot sign a contract that has gag clauses in. And I have yet to find a contract that I've reviewed that doesn't have gag clauses. Checklist number 2, group health plan service provider disclosures. We've talked about this a little bit already, but the highlights of it is if you have an organization that's receiving or an individual that's receiving at least $1,000 in compensation, the plan sponsor, it's the plan sponsor's duty. And for the longest time, I think a lot of plan sponsors, when we talk to them about, hey, did you get your disclosure document? They're like, no. Well, it's not the responsibility of the broker to bring the disclosure document to you. It's the responsibility of the plan sponsor to request it. Okay. So you need to be clear and understand that, first of all, you're the one that's got to request the information. Second of all, the plan sponsor uses that information to determine reasonableness. Well, how do you go about determining reasonableness of services? So you have to have a strong understanding of services that you're receiving. And in the brokerage world, it's kind of a, you know, a, a, a blanket of coverages that they'll provide. Anytime you have a situation where you're talking to a broker, do you provide 55? Yeah, we'll do that. Do you provide HR consulting? Yeah. What we found in is really important, and we take this from the chapter on the retirement plan side. Employers should become really hyper focused on the services that they're looking for. Do you need population health risk management? Do you need HR consulting services? So identifying the services that you need and then pricing accordingly. And I think that's really important for employers going forward, because this is going to change healthcare and the way that we buy healthcare going forward. So failure to complete this is a prohibited transaction. That is the big no-no in employee benefits. Prohibited transaction is an absolute disaster that can be applied to any company's plan, whether it's a 401k plan or a company health plan. So there are some recommendations. Obviously, if you haven't received your disclosure, you need to start documenting, first of all, that you submitted a request for a disclosure. Second of all, you need to follow up if you haven't gotten it in 30 days. And if you don't get it in another 30 days, then you need to turn around and submit to the Department of Labor that you requested with this documentation for information on compensation, and then start the process of looking for a new advisor, because this is a situation where being transparent and being compliant is going to be very important going forward. Okay. One of the things that we've done, and I want to share this with you, is why is broker compensation being reviewed? Well, first of all, it's not a situation where, it's not like you go in and you're buying, a bottle of milk and it's $4. Okay, there's variance or disparity across the board. And what we did to kind of illustrate this for you is to just kind of show a comparison of organizations by company size. And this information was all derived from 5500s that are reported with the compensation. And you'll see that, take for example, 300 to 450 employees, the highest compensation in that group was 192,000. The average number of employees was 437. And on a PEPM basis, that's $36.74. The lowest was 23,549. And the number of employees was, the lowest number was 304 for a number, which put the PEPM at $6.46. I mean, that's a huge disparity there. And this all leads back to identifying the services that you need and then pricing accordingly. 90% of this business is still built on compensation. It's moving towards fees. It's the same thing we saw in the retirement space. We had individuals that were being paid commissions to manage retirement plans. And more importantly, those same individuals were the individuals that were soliciting your employees for annuities and other various products. That whole industry has been cleaned out. And I think through this legislation, we're going to see the same thing happen. We're going to start seeing the compensation numbers tighten up, and that people are going to have a better understanding and become better buyers of their services. So I put together a list of 5 questions that you need to ask your broker. Okay. The first one is, have you removed the gag clauses from all or any of my contracts that would prevent me from accessing data, a third-party audit, or a claims review? Second, have you provided me with a complete list of all sources of income that you receive associated with your benefits program for my organization, and a listing of the services that you'll perform over that same period? So what the Department of Labor has said in their legislation is tie compensation to service. And what we've seen in this, this first iteration, this rollout, is most of the disclosure statements say we're making, $10,000 on this, on the dental plan. Okay. But it's not tied to a service. It needs to be tied to a service. Thirdly, will you act as a fiduciary on my health plan? Very important. I mean, these are the people that are advising you on your plan. Fourth, will you create the key performance indicators required to measure performance of my health plan? Well, the key to running a fiduciary process and governance really leads into identifying key metrics and what is the highest value or the highest opportunity within your organization. So when you look at your health plan, again, looking at claims data, what's going to provide you with the highest value or the highest return? That's a key metric. And for organizations, identifying those and then working towards solutions to try and reduce those costs are going to be really important. This is a role that you need to know, is the broker going to assist you in this or not? And are you willing to put your fees at risk based on success indicators that we establish together and measure and accomplish for the organization? Okay. So we've had a situation where we've seen, compensation continue to go up on an annual basis because of increase in claims and administration, causing the rising costs of healthcare. And so the brokers have benefited from that. Now we're getting to the point where employers should be asking their brokers to start putting some of those fees at risk. You need to start implementing solutions that are going to provide a way to invert this curve in healthcare. And there's a lot of opportunities out there for employers to do this. In the past, your discussion with your broker when it came to, why is this continuing to go up? No one could ever put any fingers on it. You've got the data, you've got transparency, you can tie the services together. The ball's in the court of the employer to make this happen. So The next piece is the mental health checklist, and employer health plans must be prepared to provide, especially if you're self-funded, a written analysis of how the plan compares to the Mental Health Parity Act rules on non-quantitative treatments and limitations. These are referred to as NQTLs upon request. We're already seeing soft audits in this area. So if you're an employer and you have a self-funded plan, you got to make sure that these are being done. The Department of Labor, Health and Human Services are starting to do soft audits in this area, and they're not taking kindly to it. I told you about the story in the front end about the mental health parity and Congress and the Department of Labor and the failure. The first thing they put together was a wall of shame on the website, posting the names of the organizations that they had audited that had failed the mental health parity review. So this is a situation where they take this very highly, and for employers to start paying attention to and really get an understanding of what's the TPA providing as far as reporting. Are there any additional reporting requirements? Because you're going to see a lot of organizations getting bare bones information, and unless you understand what the true requirements are for mental health, you could be left hanging in the wind. Medical and drug cost reporting requires group health plans and health insurers to report detailed data. This reports were due on December 27, 2022. The information resides with the insurer, and the departments don't want to shift self-funded plan sponsors' responsibilities to vendors. So what's important here is general good faith compliant. There is no general good faith compliance, meaning don't rely on your TPA to meet this compliance requirement for you. It's important that you understand what the requirements are from a reporting standpoint and cross your T's and dot your I's to make sure that it's been completed. Number 6, surprise air ambulance bills, and this is a situation, no surprise bill coverage. Obviously, what people need to understand is that under this piece of legislation, people that travel outside of the network and then for whatever reason are forced into a situation where maybe they need air ambulance coverage, this is protecting those enrollees from any type of significant air ambulance bills. And so it's important that you understand that there are protections that are being applied under the no surprise, and understanding this is part of a general committee discussion that should happen as far as your healthcare committee within an organization. So we do have some breaking news, and I'm going to turn this over to Deb Parch. She's going to announce what's going on. This is really important for everybody to listen up to. So Deb, take it away.
All right. Okay. Thanks, everyone. You may have noticed I am not Hugh O'Toole. I work for Hugh, and he had an unfortunate personal situation, but I am happy to be here with you. And what we're seeing now is there was, as of February, just a few days ago or a few weeks ago, February of 2023, a frequently asked question document has been issued on the Consolidated Appropriations Act, in which there has, as time has gone on since the list was first published in December of 2020, where the removal of gag clauses was to be taken by plan sponsors on their direct and indirect contracts. The frequently asked question now as really gave additional clarification to what these gag clauses are. And I think the best way to illustrate what these gag clauses are is just through an experience. So Inovu, we're a data analytics company and help analyze the data and work with advisors and plan sponsors to understand their costs and manage their benefits. We have a 7,000 life employer who had a situation where they are working with their legal counsel and they reviewed a contract. They had a very good advisor and they had identified a few of the gag clauses that Patrick had alluded to. And essentially, this is even before the CAA. The carrier made the advisor choose that if the employer and advisor wanted to see their data, they had to choose between getting the financials, the allowed amount, which is the total cost of the claim, or get the provider information. They had to make a decision between one or the other. Now, as an advisor and a plan sponsor that wants to make actual decisions about network management or where these high-cost claimants are getting their care for enhanced care management, you need to have both pieces of information. So what the government ended up doing is saying, first and foremost, plan sponsor, it is your data. You should be able to get that. You are required to get the data from your, you are required to not have any gag clauses in your contract that prohibits you from getting your data and having any restrictions on how you use the data. So they can say in the contract, we restrict you from being able to benchmark providers or create incentives to encourage people to use high quality providers over another, or doing cost and quality comparisons. Those are restrictions that are not permissible. Those are considered gag clauses. Furthermore, that this employer being asked to choose between having an allowed amount or getting service codes, such as what was the service provided and who was the provider that they're seeing, in order to make sure that their network costs are being managed, those are not permitted. They should be able to receive all claim and encounter information. Any restriction on getting that information is considered a gag clause. And then how they use it. So an advisor is typically, just like Patrick mentioned about direct and indirect comp, benchmarking and seeing where those fees are aligning to see if they're reasonable. Plan sponsors and advisors need this information to be able to freely benchmark, compare providers, analyze the data, and they're for all legal reasons, just to manage the plan, establish the designs, set the financial obligations, making sure that they're putting quality improvement initiatives in place. And finally, there should not be restrictions on the ability for an employer to share the data with their business associates or direct the sharing with the business associate. So when Patrick had mentioned the attestation that's needed at the end of this year, this attestation does not only apply to the contracts that the employer signed directly with the BUCA or the TPA, it applies to the business associate contracts. And so what Innovu, as a data aggregator, supports the advisor, supports the employer. Innovu gets direct data from the BUCAs and the TPA. And often, unless it's a three-way or a four-way non-disclosure agreement, then we have a direct contract. And if there are gag clauses in contracts with your business associate, the employer has to attest that those gag clauses were removed as well. So it's not just the ones that the employers actually put their signature on that contract. It applies to all of the contracts that manage their plan.
Yeah, I think that's a great point, Deb. I think the first thing that's really important as part of the FAQ that came out over the weekend was that it states in there, FAQs have been prepared jointly by the Department of Labor, Health and Human Services, and Treasury. So this is aligned completely across, that there's no infighting or anything like that. We saw that infighting in legislation that on the retirement plan side, where DOL would pass something, but then the SEC would step in. In this case, it's completely aligned across the board. They all agree. So very important for people to understand that it's alignment. And as you indicated, those business associate agreements, do pull in And so it makes it even more important that employers understand, hey, if you have that language in your contracts, and I just reviewed a Cigna contract that said, hey, we'll let you allow you to review claims data on the first 225 claims. After that, you can't see anything. Well, that doesn't do anybody any good. You need all of the claims data so that you can look at it. And so that is a form of a gag clause that's no longer can exist in the contract. So what do employers do? Well, they need to start looking at relationships that are independent from these BUCAs. BUCA being, Blue Cross, United Healthcare, Cigna, Anthem. And so they are the ones that are typically have these wrapped contracts with this language in it. And if you move to a true independent solution where you've got a TPA, a PBM, you've got your network of physician and hospital, now you're in a situation where you can manage and negotiate those contracts and be in a position to get the data that you need working with an organization like Inovu. And that's really important.
Thank you, Patrick. So I'm going to go through, Patrick had mentioned and focused early on about the Consolidated Appropriations Act. There's two other pieces of legislation that's on the top half of this slide. TICRA, which is the Transparency and Coverage Act, as well as the Hospital Rule Act. Both of these require public disclosure of pricing data. The things that you may see, for those of you who have access to your paid claim data, you can see what you've paid, but you don't really know what was charged. You don't know if it's appropriate. You don't know what the hospitals are pricing, and all of those were very obscured. And what TICRA does on the left, plan sponsors had to publish a website, a self-service tool of 500 shoppable services for their employees to be able to see that. And what that requirement does is these plan files have to be made public. As you can see in 2023 and 2024, what's a shoppable service? Shoppable service is one where a person schedules for a procedure in advance. So this could be a colonoscopy. It could be a knee replacement. Those are different services, and there's a list of 500 of them. So the great news for employers and advisors is right alongside this, there's the hospital transparency rule. And what this did is required public disclosure of hospital information about what their charges are for all procedures that they do. And so this is just a high level summary. There's all these nitty-gritty things of timelines, but the important part is, for the first time, we're getting more transparency of what healthcare costs. What does a doctor charge? What does a payer pay the doctor? What does the hospital charge? What does the payer pay the hospital? So how does this information that's never been available before, how can advisors take advantage of this? And one of the things that Inovu has done, and you can see here, is we create and aggregate all of this data together. So briefly, on the left-hand side, an employer may have several data sets. And as Patrick said, a lot of these are governed under different ERISA requirements like medical and pharmacy. You'll have your plan design data, your HRIS. There are other data sets that may not be required or fall under ERISA that you can aggregate, to get a complete picture of your human capital risk. Once that data is all integrated, we create a unified record. So Deb Parch is the same as Debbie Parch is the same as Deborah Parch. All of these data sets create a unified record for Debbie. We then enrich the data. So we supplement the data to have some consistency, because payers can report things different ways. And there's no necessary consistency on medical and pharmacy. And so you need to clean and cleanse the data. You enrich it with some third-party sets and put it into a view that you see in the center panel. Inovu Lens is our tool where you get standard dashboards and you get different ways that you can slice and dice and look at the data. But one of the most important pieces that has enabled advisors to have insight that they've never seen before is over here by this hospital payer data. This hospital payer data is a huge data set that is not manageable to be able to do analytics on unless you have a solution that can integrate it using these advanced technologies to make it usable. So how did we do that? So this is the tool that we've done and that we've offered employers and advisors to be able to bring the data in and be making it usable. And how we use it. First and foremost, one of the requirements is to own your data, right? Make sure you get the information. So we give you a vault. Employers and advisors have a vault where they can establish all of the data. So regardless if they change carriers, you have that information. You can get through and do health cost and quality reporting. You can look at fiduciary toolbox where you can say, if you have all of these regulations and these attestations you have to do, you can store that. So each one of these different product modules, we have 5 of these product modules with 3 additional focus points within health cost and quality, can help guide you through this to leverage all of this rich data and being able to make and adhere to your fiduciary responsibilities, which is to give your employees an affordable benefit that has good quality. So here is one of this busy slide, ultimately shows what the role of the advisor is in these relationships and taking in this employer data and being able to not only negotiate and choose your TPA and PBM to administer the benefits, but when you layer on a data analytics solution, you can collect it, you can frame the data, target different populations that you want to have action on to manage your costs or improve the healthcare quality and outcomes of those individuals. And you may choose to point in different programs. You put in a digital health coaching program. You put in something to treat diabetes. You put in something to treat musculoskeletal conditions or target those centers of excellence for imaging or centers of excellence for knee replacements. Those are other programs that advisors can layer on. And all of these different types of programs that are over here on the left-hand side, on the right-hand side, when an employer chooses to do that, then the important part of this is then measuring the outcome. Did you get the return on your investment? Are you making an effort to improve the quality of care that's being offered to your employees? So these are a lot of data-driven solutions and tools that are available in the marketplace that advisors and employers and others can take advantage of to help not only comply with the legislation, but to improve the overall management of your plan. With that, I'm going to transition this over to my colleague, Mick. Mick, I think you're on mute.
There we go. I'll jump to the right slide. And thank you for bearing with us as we get through to the proper slide. But ultimately, I'm going to give you a sneak peek on how you can take the new rules around your fiduciary responsibilities and your data, now that you have access to that data, and build a fiduciary process around an ongoing annual fiduciary management of your data to make sure that you're saving the right amount of money and introducing new and different ways. And I believe we'll probably be announcing a follow-up webinar in March where we'll get into more details around this specific data. But I'll give you a quick sneak preview because we only have a few minutes left. So as we look at building your organization's future key indicators, as Deb mentioned, building ROIs and OKRs and KPIs are all going to be very core to managing your health plan and being a fiduciary. So as we look at the data that you receive, it's great because now we're going to have your data, we're going to have the community hospital transparency data, we're going to be able to compare those two to understand where you're going to be able to send your people to get the right services at the right cost at the right time. And the other side to that double-edged sword is if you're getting data today, a lot of times what we see in the marketplace is some really generic reporting that's not actionable. You're going to want to take those reports and put them aside, toss them in the garbage, because those are not going to be useful anymore. And for a lot of organizations, they get data, but they don't know what to do with it. They don't have any way to take that data, make it useful. Now the government is basically saying, now that you have the responsibility to take that gag files out and get your data, you can no longer sit on your hands. So it is a double-edged sword. But as you start thinking about, okay, how do I set ROI targets? We would recommend cost, and you could go per unit, per episode, per condition. We would recommend that you set targets based on the health of the population. So whether those are the individuals, and again, all of this is de-identified information. So you won't see that McHanifin has, GERD or, hasn't had my colonoscopy. You'll see by the groupings of those individuals or those disease-related groupings. And then we would also recommend that you set ROI targets on your risk, because again, if you can impact and mitigate the risk of your population, you can improve the health of your population, you can drive down the cost per unit. And so all three of those, being legs of a stool, do need to be identified, benchmarked, and measured and reported. So again, focus on actionable metrics, focus on condition-specific data, understand your episodes of care, create trending for these categories, and get ready to report on them. So if we look at a group, about 500 employees, have about $5 million in spend, about 1,100 participants. Your claims are 78 to 80% of your costs. You're spending about $3.75 million. Your retention, which is your admin and your other charges, the commissions, all of those things is 10 to 15%. You're probably spending about 750 there, and your stop loss is about 10%. Now, as we look at BUCAs or large health payers, they're doing the best they can, right? They're trying to go out and contract with the providers, but unlike going to Home Depot or Costco, which buys on bulk and passes that savings to you, health systems tend to act completely inverse of that. So the larger the health system, the more patients they have, the more leverage they have with the health plan. Frankly, they can leverage higher prices than the independents, that if the health plan loses the independent practitioner or specialty group, they didn't lose that many patients. Oh, well. So again, when you get that notification from your health system that says, hey, we're having an impasse on negotiations with health system A, take that seriously, because they're doing everything in their power to help manage those costs. And if that health system says we need to leave that payer, maybe that is, right now we all look at it and we get all upset because we're going to have so much disruption, but that is part of the negotiation process. Now, the other side of that is your BUCA charges you your stop loss. Oftentimes it's bundled, your admin, your PBM. A lot of those charges are based on a fee of your claims, which can, as a fiduciary, create a conflict of interest, because the higher the claims, the higher the stop loss, the higher the admin. Again, when we're looking at BUCAs across the country, we're seeing that many of those insurance companies are now starting to either own, merge, or become partners with hospitals and clinics. That, again, from a fiduciary status, could create a conflict. And again, when we get together next month, we'll talk a little bit about this more in depth. And again, your BUCA is held to an 85% medical loss ratio, but frankly, you got to pay attention to the details in the contract, because there are a number of places in the contract where they turn actual admin charges into claims charges so they can get by that 85%. We'll show you how that works when we get back together. So I'm going to show you, one company, that company that had 500 employees spends about $5 million. If we do it, as Deb mentioned, we take a look at the community data and our data that you have as your employer and say, okay, let's just dig in. We look at diagnostic colonoscopies. This is just the colonoscopy itself. It doesn't account for the full set of services like the outpatient or the inpatient or any of those types of services. But if we look at it and just say, okay, our average paid was about $3,000, we could buy it for $500. here's how many events we had, the math becomes pretty simple. You do the same thing for joint injections. So as you start thinking about, okay, where do I fall on the spectrum from high to low? And where does the quality of the provider come in? And can we move people to the lower quadrant of cost and the higher quadrant of quality and still have great outcomes at lower cost? The answer is yes. Again, we look at just simple office visits, a low acuity office visit versus a 900 office visits, and you take the high acuity and do the same. We look at knee and hip. We've got, certain number of events. We go through and we do this whole thing, and we literally can start adding up the opportunities for savings. So as you look at that same organization that was spending $5 million, and because your admin costs and your other costs like stop loss are a derivative of your claims, if we can reduce your claim spend, we can reduce your stop loss spend and your admin expense. And so as you look at it and say, okay, well, is it really possible to save $2 million on a $5 million plan? The answer is yes. That answer is all in your data. And again, as we get together next month, we'll talk a little bit about where else are there savings. Certainly auditing, contracting, as we look at all the things in red are things that you're now going to have to do, but certainly other buckets of care and other buckets of strategies that can help your committee really drive down the cost of your health plan and deliver a high quality plan at very low cost to yourselves and to your employees to be a good fiduciary. I'm going to give Brian a couple of minutes here at the end, because educating and communicating with your employees once you do all of these things becomes paramount, and doing it once a year at open enrollment just ain't going to cut it anymore. So I'm going to toss it over to Brian for a couple of minutes at the end to talk a little bit about learner benefits.
All right, thank you very much, Mick. I believe I'm unmuted. Let me hand over to my slides. Again, I apologize for the jumping back and forth between slides, but when you're trying to navigate a presentation for multiple cities across the country, we got to do this stuff. So let me just have actually 2 minutes of your time just for a couple of closing remarks. I actually got a few emails from clients going, well, what does this have to do with communications? Well, let me get to that point in just a second. What Learn Your Benefits is we're a multi-featured employee benefits communication solution. You've probably seen our emails or saw them. If you are new to us, we appreciate you checking us out. But at its core, think of it as sort of like QuickBooks for employee benefits communications. It's an entire suite of customizable features that you can use to communicate year round. And then it's extremely flexible the rest of the year. So its goal is to help you increase the effectiveness and the accessibility of information for your employees as it relates to your benefits. And here's what I mean by that. I'm going to mix a couple of metaphors here. So now is the time, especially in this day and age, especially with everything you just saw here in the last hour, now is the time to get across the finish line for your communications. This is the mixing of the metaphors here. I believe communications is a catalyst for a well-built benefits program. If you're working towards your fiduciary obligations under the Consolidated Appropriations Act, you're looking to control costs. If you're implementing solutions like Deb just talked about, from gastrointestinal to health coaching, primary care, diabetes, imaging, cancer, if you're looking to implement all of these changes and you implement all these plans and you don't have solid communications, all those products you just implemented are inert. They're going to sit there. They're not going to be utilized. Initially, in the first year, you get 5, 10, 15% of your organization to begin taking that. With communications year round, you now have a catalyst. You're now going to implement and activate all those products and all those solutions to drive towards the results we just talked about underneath the Consolidated Appropriations Act. I truly believe it, and we have the ROI and the data to prove it. What separates Learn Your Benefits that'll help you get across the finish line is, the bottom line is, we're going to help you communicate year round, whereas any other solution I'm aware of is largely stagnant the rest of the year. Check us out on our pricing. In fact, we're going to have free trials and e-commerce coming up here in the next 45 days, where we're going to be relaunching really industry-changing prices and approach to these types of communication tools, bringing Fortune 500 level communications to any size organization. And it'll be customizable year round. And we also offer significant custom videos for those that have these complex benefit plan implementations like we talked about today. I want to take a moment to really thank our presenters. These people are experts in their field. Obviously, Deb Parch referenced Hugh O'Toole. They're both equally capable in this space. Mick Hannafin, Caveat Emptor Consulting, Patrick Williams with One Vision, Hugh O'Toole at Innovu. These were your hosts. Well, Deb Parch at Innovu, excuse me. These were your hosts. The slides and links to their websites are at info.learnyourbenefits.com/slides_handouts. This being said, watch for an email. We'll get an email to you probably in the next 2 or 3 days. Again, linking to all these experts' websites, and then there'll be a link to these slides as well. And so additional thought leadership for us, Learn Your Benefits, is on the screen here, blog.learnyourbenefits.com. Follow us on LinkedIn. Certainly check us out for other past webinars at that same website you'll get. Future webinars, subscribe to emails. We do have a virtual demo, check us out. We got over 100 educational videos coming. So again, I won't belabor you with that information. So thank you, experts. Thank you, everyone, for joining us. Thanks for taking an hour out of your day and learning with us. Watch for future emails on clarifications and more information. This is a hot topic. Like a catalyst, it's boiling out there. So let's keep an eye on this. So more information on us, learnyourbenefits.com. Email us at info@learnyourbenefits.com. Take care, everyone. Have a fantastic day, and we'll see you at the next webinar. Bye-bye now.
Bye.